Hello, my name is Albert Lai. I'm professor of neurology and have been taking care of brain tumor patients at UCLA since 2005. And overall, I've been at UCLA since 1999. My passion is caring for brain tumor patients and increasing our knowledge about these tumors through basic and translational research. My laboratory is particularly interested in MGMT methylation and IDH mutant gliomas. My talk today will be on the topic of chemotherapeutic and biologic agents in the treatment of gliomas. Glioma treatment poses many challenges. Tumors are molecularly heterogeneous. Tumors differ from one patient to another, and cell-to-cell heterogeneity may contribute to resistance. Tumors are not particularly radiation or TMZ sensitive, which is a chemotherapy. And these tumors are also not well circumscribed, meaning that they are not easily removed. The tumor environment may also prevent effective delivery. The current standard of care for upfront therapy for glioblastoma is surgery, maximal safe resection, debulking, and establishing the diagnosis. Radiation, followed by radiation and temozolomide. And temozolomide is either given for generally 6 to 12 months. Occasionally we have gone longer to 12 to 24 months, but really only rarely do that. If there is progression, we stop temozolomide and consider other options. So what is temozolomide? That really is the most common chemotherapy that we use for nearly all gliomas. It's an oral agent. It crosses the blood-brain barrier. It's a DNA alkylator, and the temozolomide alkylated DNA can be repaired by an enzyme called MGMT. It has tolerable side effects, including nausea, which is prevented with Kytril or Zofran, causes fatigue, can cause bone marrow suppression, which is why we need to check blood counts while we're doing this, and it also causes constipation. So in 2005, a large randomized study was conducted, and this forms the basis of our standard of care. It was a phase 3 study for upfront glioblastoma with radiation plus or minus temozolomide. And this is the protocol or procedure that they settled on, where there is radiation with concomitant temozolomide given daily, followed by adjuvant temozolomide, where each cycle is 5 days on, 23 days off. And there is a specific dosing scheme that differs for the concomitant phase versus the adjuvant phase. One thing to note, and sometimes this is surprising to patients, is that when we do the first adjuvant monthly cycle, that is at a lower dose than what we would like to do for the remainder of the cycles. So there is usually a bump up for the temozolomide dosing. And this was established in 2005, and the results clearly show from this Kaplan-Meier curve that the 2-year survival improves from 10.4% to 26.5%. Clearly where the patients that received temozolomide in addition to radiotherapy did much better than the patients with radiotherapy. Recognize that these numbers were published in 2005, and the overall our ability to help patients live longer has actually increased several months from the data that is shown here. It's not exactly clear why, but what I'd like you to see here is just generally that clearly we have demonstrated here that temozolomide plus radiotherapy is better than radiotherapy alone. The next thing that I think was very important in this study was that it proved the existence of a biomarker called MGMT promoter methylation, showing that patients with MGMT promoter methylation, when challenged with this regimen, did much better. And that's indicated by comparing the orange curve versus the blue curve. And that shows a clear distinction between patients with methylated MGMT versus unmethylated MGMT. What it also showed, if you look at the radiotherapy arms alone, where you look at the light blue versus the red, patients that did not receive temozolomide with the methylation, MGMT methylation, also did better. So that suggests or indicates that MGMT promoter methylation is both predictive and prognostic. And I think that we are always looking, when we have a patient that we're seeing for the first time, one of the things we want to know is, what is their MGMT methylation? And just briefly, MGMT methylation or MGMT promoter methylation results in the gene silencing of MGMT. And basically, that shows that when you have methylation, you silence the gene. And what that means in the case of MGMT, as I mentioned before, that MGMT is a repair enzyme that actually repairs the damage done by temozolomide. So by having MGMT methylated, the repair enzyme is actually present at much lower levels and is unable to repair the temozolomide damage. And we can test for this in many ways. Nowadays, we are doing a send out where it's a form of the methylation specific PCR. It's actually quantitative, where we show the presence of MGMT methylation in a particular region. This has basically replaced MGMT IHC, which really doesn't approximate things quite as well. And what we found when we did our own research looking at a group of retrospective patients here treated at UCLA was that if you had both low IHC and methylation, that predicted the best outcome, which is in the blue solid line here. However, again, the MGMT, if you had only one test to have, you really need to have the MGMT, true MGMT methylation test. What we also found in subsequent research was that now that we have a numerical score for MGMT methylation, does that numerical score seem to mean anything? And I'm not going to show the data, but basically, if you have a very high methylation score, it didn't seem to help compared to patients with lower, but we did expose or identify a group of patients with intermediate low methylation that actually behaved well, like similarly to MGMT methylated. So the take home is that the absolute magnitude doesn't matter that much, but if you were just below the threshold to be called methylation, you still could basically phenotypically be methylated. So the future directions in temozolomide therapy is, well, clearly we're helping patients, but we're not curing patients with this standard of care radiation and temozolomide. What are the combinations that we can add to this backbone? One of the things I'll be talking about later on is that it's probably not Avastin. Number two, what are effective treatments for MGMT unmethylated patients? And a number of clinical trials are being designed to specifically look at either MGMT unmethylated or MGMT methylated patients. Can we improve on this standard of care with alternative TMZ dosing schedules to deplete MGMT? There was a randomized study, RTOG 0525, which basically showed that there was no difference between the standard adjuvant temozolomide 5 days on, 23 days off, compared to a dose dense schedule in newly diagnosed glioblastoma. This was a negative trial. Again, another issue is, what is the duration of therapy in a patient that is doing well? Should it be 6 months? Should it be 12 months? Should it be 24 months? What we are doing here at UCLA is 12 months. But if you ask me strictly, what does the data tell us in terms of really what we know? based on the clinical trial that I showed you, that was designed around 6 months. So there are a number of neuro-oncologists that are recommending 6 months only. And I don't think we know for certain which one is the best, but 6 months or 12 months, I don't think either is incorrect. But you may have to see differences of opinion. We're also looking into, and I think this is pretty well settled, that elderly patients greater than 65 do benefit from temozolomide, especially if they have MGMT promoter methylation. So what happens if a patient progresses through temozolomide? And again, TMZ is an acronym or abbreviation for temozolomide. Well, it's usually detected by close MRI follow-up. And we confirm, this is very important, we need to confirm that the MRI change is tumor growth versus radiation necrosis. And one way we can do that is to do a DOPA PET scan, or looking at perfusion studies, or by following the patient with serial MRI scans and seeing what the fate of these MRI changes are. If we are convinced that this is tumor growth, temozolomide is stopped, and then the selection of the next option requires careful discussion with the patient and patient's care team. So the options at progression/recurrence, surgery is one of them. It's always would require effective systemic therapy afterwards. Gliadel has been an option. I don't think we've used it very often here. Repeat radiation is usually not recommended unless we've exhausted all other treatments, or if the radiation is done to an area that has never had radiation before, or that it's been over 10 years since the initial radiation. So we're really dealing with also systemic agents, and there's non-clinical trial versus clinical trial therapies. And I'm going to be talking about the non-clinical trial therapies, ones that we do not need to enroll a patient into a clinical trial in order to get exposed to these, or in order to be treated with these agents. And so I want to make a distinction between chemotherapy versus biologic agents. Chemotherapies are the traditional ones, like temozolomide, CCNU, carboplatin. Biologic agents are those that attack particular signal transduction cascades, such as Avastin, which is also bevacizumab, such as tyrosine kinase inhibitors, etc. In terms of combination approaches, we generally cannot combine two chemotherapies because their effect on bone marrow suppression would be too great. Although there is data suggesting that temozolomide and CCNU can be combined in the right doses. We can combine a biologic and a chemo, or a biologic with a biologic. However, most of the combinations that we really try to move forward with are those that are being investigated in clinical trials. So in terms of the chemotherapies, this list is not really expanded over time. I talked about temozolomide. That's really our most important one. Second line is CCNU. This is also called lomustine. It's an oral medication. We give it at a dosing of 110 milligrams per meter squared out of 1 day per 42. What we have seen, so that's a 6-week cycle where the drug is only given on 1 day. And what we've seen is more myelosuppression, meaning that there's more risk of reducing white count or platelets. And we usually give 6 cycles max because we do not want to induce pulmonary fibrosis. Another agent that we use is carboplatin, which is given intravenously. It is dosed at something called the area under the curve, AUC equals to 5, and that's 1 day per 28. Other things that we're using more rarely are etoposide, which is oral, 50 milligrams per meter squared, 21 days per 28. The main difference here is that there is hair loss. Carboplatin seems to behave very similarly to temozolomide in terms of side effects. Another one is procarbazine, which is oral, 60 milligrams per meter squared, 28 days on, 28 days off. Another one is CPT-11 or irinotecan, and that's an IV medication given 1 day every 2 to 3 weeks. Our typical response rate is approximately 5%, and the progression-free survival at 6 months, 20 to 40%, and questionable increase in overall survival. So generally, what this means is that the results of treatment with these agents at recurrence are generally not that good, and that really forms the impetus for us and for patients to want to enroll in clinical trials, which have the hope of potentially improving our outcomes. PCV is something that we are not only considering an NV tumor with 1p19q codeletion, but we're actually doing this. And these patients with 1p19q codeletion occur in the setting of the IDH mutation, and those are patients that are now known as oligodendrogliomas. And just so that you know what this is, PCV includes two of the medications that I talked to in the previous slide. Procarbazine is P, lomustine is C or CCNU, and vincristine, which I haven't talked about before, is an IV medication that is given twice per cycle. And just like the CCNU, this is given for 6 cycles. And again, we have seen, and the whole field has seen significant benefits of the addition of PCV to radiation specifically for the oligodendroglioma group, where we can actually see improvements. So if you look at both panels A, the addition of PCV significantly alters the outcome as seen by the flattening of the yellow curve. And one thing that's extremely significant here is that when we look at how this curve behaves, it's not going to 0%. It's actually flattening out at 50% after 14 years. So in this study, it looks like maybe 50% of patients could actually be cured or have extremely long-term survivals. And this is based on patients with grade 3 oligodendrogliomas, which at the time were grade 3 tumors with the 1p19q codeletion. So I think this is very significant, and it says that if you have a molecularly confirmed oligodendroglioma, that this is an area where our treatments can be extremely effective. And I've seen this over and over with patients that I've been taking care of, is that this is something that I almost expect rather than being surprised about. PCV is also appropriate for any low-grade glioma. And this is actually the direction we're going in right now, based on a study, RTOG 9802, which said that radiation and immediate PCV was superior to radiation only. And so as a low-grade glioma, we are moving in this direction. The reason that we're not doing temozolomide as much as we used to be for these patients is that there's no data as to whether TMZ will be equivalent to PCV in this setting. However, I don't think doing temozolomide versus PCV would be the wrong choice. I don't think there's a true right answer here. However, we have been favoring radiation and PCV together. And that's just, again, because of the absence of data of whether temozolomide itself is equivalent to PCV. Moving forward to biologic agents. So in terms of FDA approval for glioblastoma, we have Avastin. I should also say that the generic name is bevacizumab. This is an IV medication. We give it at 5 to 10 milligrams per kilogram every 2 weeks. It's an anti-VEGF antibody, and it was granted full FDA approval for the treatment of recurrent glioblastoma in 2017. We also, and I will discuss these, are using off-label treatments. And off-label is another way of saying they are not FDA approved for brain tumors. They are FDA approved for other types of malignancies, but not brain tumors. What that means is that we can actually prescribe these, and we also need to get help if the insurance will not pay for it. And usually the pharmaceutical companies that make these drugs do have patient support programs for access to these drugs. And things that we have been using for EGFR inhibitors, patients that have EGFR mutations, are lapatinib, osimertinib. More recently, we've been using immune checkpoint inhibitors, which have revolutionized the field in other malignancies, and we're actively studying the role of these in gliomas. Those are nivolumab or pembrolizumab. In addition, for patients with a BRAF V600E mutated gliomas, there is data now supporting the use of dabrafenib, which is a V600E inhibitor, and tremelimumab, which is a MEK inhibitor. Another exciting area is in specific IDH mutant inhibitors, ivosidenib, which we use orally at 500 milligrams daily. This, I think, is very promising. We have been running clinical trials using similar drugs, newer generations of this. Also, there's an IDH2 mutant inhibitor that can be used off-label as well, although those mutations are much more rare than the IDH1 mutation. So again, the only true biologic agent that is FDA approved is Avastin/bevacizumab. Everything else is being used off-label, but I think we've made tremendous advances and maybe seeing a paradigm shift in the near future as we read out some of the clinical trials for agents such as IDH mutant inhibitors, novel EGFR inhibitors, and immune checkpoint inhibitors. So since we use Avastin very frequently, what is this? It's an anti-VEGF antibody. Also, its generic name is bevacizumab. It's a humanized anti-VEGF antibody that's administered intravenously. It has anti-angiogenic and anti-edema effects. It was FDA approved as single agent for recurrent glioblastoma conditionally in May 2009 and fully in 2017. So VEGF is vascular endothelial growth factor. It is a homodimer, molecular weight 45,000. It occupies a central pathway in tumor biology. It's an endothelial mitogen survival factor and permeability factor. It promotes blood vessel formation and edema. And these are some of the results that we were seeing early on. These are from before 2009, where we saw dramatic effects in the reduction in contrast enhancement, comparing the right to the left, as well as significant decreases in edema. And here's just another example of before and after, where we see decreased contrast enhancement and decreased edema. And these are really the features, the imaging features that we see from the use of Avastin. We were one of the early centers that were doing research in this, and we did some of the initial studies, or were involved in some of those initial studies. When I am placing a patient on Avastin, I one of the most important things that we have to do is inform the patient and patient's family about possible side effects. The main one is this 1% risk of hemorrhage. This is generally CNS hemorrhage. In other words, bleeding in the brain can occur, and that occurs about 1% of the time. And I also say that that also means that 99% of the time it doesn't happen. We have seen things like GI perforations, particularly in patients that have had prior abdominal surgeries. This also happens at a low rate. We have seen strokes, ischemic strokes, generally asymptomatic, and that occurs in the 1% range as well. We have seen the development of venous thromboembolisms, such as blood clots in the legs or lungs. This seems to be more frequent. It seems to be an association, but we also have to realize that these patients with brain tumors have a high risk of developing VTE on their own. We see proteinuria. What's not on here is hypertension. There can be wound healing complications, and those are the main ones specific to bevacizumab. So Avastin has emerged as one of the most important treatment options for glioblastoma. It's anti-angiogenic. It has possible direct anti-tumor effects. It has been thought in the past that it may potentiate concomitant chemotherapy. I'm not sure if we're actually seeing that. Probably its most robust effect is an anti-edema effect. And by doing so, it allows us to reduce corticosteroid use. And it seems to be associated with improved quality of life and potentially maintaining neurocognitive function. Although some of the more recent studies have contradicted this idea. But I think as we see how our patients benefit from this, there's a definite benefit from the reduction in corticosteroid use and the control of edema. So when we prescribe Avastin for recurrent glioma, the Avastin dosing is 10 milligram per kilogram. Well, what is optimal? How long do we continue when a patient's doing well? We really don't know. I've had patients on this for years, assuming that they don't have problems with their counts. But if they're doing really well, when do we stop it? And that's a hard question. I don't really have the answer for you. We give it every 2 weeks and usually do MRIs every 6 weeks just to review them. Fatal cerebral hemorrhage, approximately 1% risk, hypertension, proteinuria, venous thrombosis, and wound healing impairment. We used to use this in combination with CPT-11. We tend not to do that very much anymore. Going back to when do we stop, what we've found is that in patients doing really well, we can start tapering the dose down, giving it every 3 weeks, giving it every 4 weeks, giving 5 milligrams instead of 10 milligrams. So even in some of the patients that are on it for long-term periods of time over years, they may be getting it monthly at 5 milligrams per kilogram, which is essentially a quarter of the dose. So what are the future directions in this area? Well, when should Avastin be initiated? Who will benefit the most from Avastin in terms of clinical and molecular characteristics? What's the age of patients that would do the best? Does it matter if they're IDH mutant? Does it matter if they're MGMT methylated? And what is the best treatment for Avastin-resistant tumors? So in terms of should Avastin be given earlier, such as upfront, we did a prospective clinical trial. This is already many years ago, but this was the first study designed to help determine when to administer Avastin. It was non-randomized, and large randomized studies have now been reported. But basically what we found was that there was no advantage from a survival standpoint of starting Avastin upfront earlier as opposed to at recurrence. And this was the trial where or the schematic of the trial where we compared upfront with patients that had not received it at upfront, but had received it at recurrence. And so there were 2 large studies that followed up our smaller pilot study, basically finding the same thing, which was that there was increased progression-free survival, but no benefit in overall survival, indicating clearly that there was no apparent benefit to adding Avastin to the backbone of radiation and temozolomide prior to recurrence. Except in certain situations where the thought would be that the Avastin, because of its anti-edema effect, would cause improvements or be associated with improvements in quality of life. So should Avastin be used up front? Well, with the best available data, it does not appear that upfront Avastin is beneficial for the majority of GBM patients. There may be subpopulations of patients that will benefit from early use of Avastin. These could be older patients with large residual tumor, with edema, or poorly functioning patients that may have trouble getting the full dose of radiation. So if we're not going to do it up front, then when should Avastin be initiated? We did a study in 2014 where we found that the deferred use of bevacizumab for recurrent glioblastoma did not appear to be associated with diminished efficacy. And this is the Kaplan-Meier curve, which shows that progression-free survival with bevacizumab seems to be independent of the recurrence at which it was initiated at. What we did find was that some patients should not be delayed because they had rapid deterioration, where if we know that this drug works, but it appears clear that the patient is not doing well enough and may not even get a chance to get it, so that's the patient where we should be using it as early as possible. In terms of Avastin resistance, many patients seem to demonstrate Avastin failure. And this reinforces the need to study and understand the Avastin failure tumors. What is the Achilles heel? Can this be exploited? The first step is to characterize molecular alterations occurring in tumors using the most advanced genomic techniques available. And then thinking about rationally combining Avastin with chemotherapies or radiation. I didn't mention this in my introduction, but I did want to talk about Optune. It doesn't really fit into, it doesn't fit as cleanly into the categories that I've been talking about, but Optune is a FDA-approved treatment, and originally in 2011, and then in 2015 for newly diagnosed glioblastoma. Optune works through the use of something called tumor treating fields, and it requires the placement of these electrodes onto the shaved scalp. And this is thought to, or has been shown to decrease the cell's ability to divide. And in 2017, the results of a randomized trial were highly significant, improving the addition to Optune tumor treating fields to radiation temozolomide resulted in a significantly increased overall survival. Of note, the Optune is given at the end of radiation, since it's impractical to give it during radiation. I wanted to briefly talk about these other off-label biologic agents that I mentioned before: EGFR inhibitors, immune checkpoint inhibitors, BRAF inhibitors, and the IDH mutant inhibitor. So I want to start with the IDH mutation story. This mutation was discovered in 2008, and there's been an absolute explosion of knowledge in this area, culminating in the development of drugs that are being used clinically at the bedside for patients with IDH mutant leukemias. So this is a somatic mutation at the R132 position. The R132H is most common. It's hemizygous. It's an active site alteration, and it's associated with younger age at diagnosis. It's associated with improved outcome, and it's a Krebs or TCA cycle component. And what we've learned now is that we now have a clear understanding of the molecular framework of gliomas. So in general, I was talking about glioblastoma previously. Those are IDH wild type patients. IDH mutant patients are all of the lower grade patients, low grade astrocytomas. And if you have the 1p19q codeletion, then those include the oligodendrogliomas. So the exciting findings in this area is that the mutant IDH1 produces D2HG, which is a gain of function mutation. This novel metabolite is thought then to trigger a cascade that may be the origin for low-grade gliomas. And so then the idea is if we can inhibit its production, maybe we can use that as a treatment for patients. So this elevated D2HG may have many roles in promoting tumors. Many of these areas we're actually studying actively in my laboratory. And now IDH mutant inhibitors are in clinical trials for gliomas. And again, I want to stress that the proof of principle that this strategy could work has already been shown based on the FDA approval of agents and similar agents for the treatment of other malignancies that also harbor IDH mutations. So early results from AG120, which is actually FDA approved for other cancers, was that AG120 is monotherapy is associated with a favorable safety profile and prolonged stable disease in a previously treated non-enhancing mutant IDH glioma patient population and warrants further clinical evaluation. And this was 2017. Where we are in 2021, 2022 is that a multi-center trial using a drug called AG881, which is a next generation version of this, has just completed enrollment for patients that have never had treatment at all. And we're anxiously awaiting the results of this. And I'm hoping that we will find that this can be very effective and potentially has the possibility of deferring or obviating the need for radiation and chemotherapy in patients. In summary, many agents have activity against gliomas. Temozolomide and PCV are important chemotherapeutic options. Avastin is an important biological option. Optune is the most recently FDA-approved option. Personalized approaches are still required. Off-label treatments, FDA-approved for other indications, are commonly used now. We would like to test those in the setting of clinical trials. And lastly, IDH inhibitors for patients who have IDH mutant tumors may be the next to get FDA approval. Just wanted to end with this slide. This is our UCLA Brain Tumor Program. We have a large team of clinicians and basic and translational scientists. Thank you very much. I appreciate your attention.